So with this video, have you did you watch it at all, or?
I'm going through
Okay.
about like bit by bit, like two
Okay.
times speed. So
Yeah, I haven't watched this video at all. I just was
I
looking at.
think let's just go through that together.
Yeah, sounds good. And do you know about Dr. Andrea Furlan, by the way?
No, I actually first time I see her videos.
Yeah, she's
She
actually,
is talking about things sensibly, so I just
yeah,
press my following button.
yeah. I think she's a physiatrist. Yeah, she's a physiatrist. She teaches at U of T at the School of Medicine there, and she works at UHN. So you know how I join on Thursdays that Echo Project Echo at UHN? You
Oh,
see me in lunchroom
oh,
on those
so
days?
she is one of the part of that
She's a
that,
chair actually.
that presentation.
Yeah, she's the chair of the whole thing.
Oh, I see.
So for that, usually it's like any clinician, it could be you or me or anybody, present a case, and then usually they have a specific topic that day, and then usually somebody, a lecturer, gives a lecture. That's how it kind of works. So she kind of just coordinates that. She doesn't really talk much. She gives some feedback, but yeah. So she was very well known, at least in Canadian academic institutions, and especially in the field of pain. And you can see her YouTube, she has like 658,000
That's a lot.
it's a lot of people, right? So a lot of reach. So anyhow, let me share the screen and then let's watch it together.
Yeah, no problem.
Share. Can you see this?
Yep.
Yeah, okay. Let me just blow it up and then let's play.
Did you know that there are 3 types of pain? In 2018, the International Association for the Study of Pain, or IASP, released a new pain classification. The 3 types of pain are nociceptive pain, neuropathic pain, and nociplastic pain. In this video, I will explain what they mean, how do we diagnose them in clinical practice, and how we treat each one of them. So, let's talk about the 3 types of pain today. To understand these 3 types of pain, let me tell you what pain is. Pain is the alarm system of our body. It is good to have an alarm system. Some people are born without the ability to feel pain and they die at an early age. As an alarm system of a house, you install sensors for smoke, break-ins, water leak, carbon monoxide all over your house. Our body has various sensors distributed everywhere. The skin is where most of the sensors are, but we also have some sensors in the internal organs. The skin has sensors to detect high temperature, low temperature.
Yep.
Sorry, did I mess up my?
I think we got a small stutter, and I cannot see your screen sharing right now.
Okay, so I'm sorry about that. Let me just share. Let me just share it again. Apologies. Can you see now?
Not now. Not now.
Share again.
Oh, yeah, I got it now.
Okay, perfect. Sorry about that. Let me just rewind that a little bit.
No problem.
Yeah, let's see. Let's go back. Yeah, sorry about that. Yes.
Yeah.
Okay, okay, there we go.
And many others. All of these sensors send electrical signals to the spinal cord. The spinal cord is similar to the box on the wall where all the wires of the house alarm convey. Here in the box, you can activate the alarm, deactivate it, turn the volume up or down, give different passwords to various people in your household, and many other adjustments. This box will communicate with the central office via telephone. The main office will analyze the information coming from your house and decide to send the ambulance, the fire truck, or the police to your house. In the human body, the brain decides what to do with the information of pain. So let's study nociceptive pain. Nociceptive pain is pain caused by an injury or a disease activating the pain receptors. That's exactly what the pain system is designed to do, to alert the brain that something is causing damage to the body. Examples are bruises, sprains, burns, bone fractures, appendicitis, menstrual cramps, heart attack, kidney stones, a surgery, a medical procedure, and many other acute events to our body. In the analogy of the alarm of the house, there is a fire in the house and the central office has to send the fire truck. Or there is a burglar and the central office has to send the police. Or there is a medical emergency and the central office has to send the ambulance. This type of pain is what we call acute pain. It is short-lived, lasts a few hours or days. The body heals and the pain stops. We treat nociceptive pain with ice packs, anesthesia, transcutaneous electrical nerve stimulation, TENS, acetaminophen, anti-inflammatories, and in some cases, opioids. The second type is neuropathic pain. This type of pain is a consequence of an injury or disease of the nervous system. The nervous system communicates with and controls the whole body, sending orders and receiving information. The nervous system comprises the central, peripheral, and autonomous nervous system. The central nervous system contains the brain and the spinal cord. The brain and the spinal cord are surrounded by special membranes and they are kind of isolated from the rest of the body and protected inside very thick bones like the skull and the vertebrae. The peripheral nervous system is composed of all the nerves that exit the spinal cord. And the autonomous nervous system has some parts inside the central nervous system and some parts outside the central nervous system. The autonomous nervous system is divided into two parts, the sympathetic and the parasympathetic autonomous nervous system. When there is an injury or damage to the nervous system, this will generate a sensation that will be interpreted by the brain as pain. But this is not actually pain from nociceptor stimulation. In the analogy of the alarm system, it's like if someone cut a wire. The central alarm system will receive a signal that someone cut the wire of your house. That doesn't seem good. Maybe someone will try to invade and they disconnected the alarm from your house. So the central office will have to do something about that. You can't just go on with the alarm wires cut off. When a nerve is injured by a cut, a pressure, or disease, it generates neuropathic pain. So the brain will detect that the wires have been cut, damaged, and the way to alert you is by creating pain. So it's a different kind of pain from nociceptive pain because here the injury is in the alarm system itself. These injuries to the pain system can happen in the periphery, the central nervous system, or the autonomous nervous system. Examples of conditions that cause neuropathic pain are peripheral neuropathies, nerve compressions, radiculopathy, spinal cord injury, stroke, multiple sclerosis. Neuropathic pain can be acute if the injury starts abruptly, or it can slowly progress in case of a nerve compression or neuropathies, for example. The treatment for neuropathic pain is different from nociceptive pain. Neuropathic pain is treated with agents that reduce the activity of nerves and neurons. These are usually antidepressants and anticonvulsants. Opioids are sometimes combined with these drugs to increase the pain analgesic effect. But acetaminophen, anti-inflammatories, they rarely have some effect on neuropathic pain. It seems that cannabinoids, lidocaine, and ketamine, they have some benefit for neuropathic pain.
Are you having trouble trying to keep up with your professor? You've got to try Otter. Here's how it works.
I don't have
Let's say I'm in class. I just hit record, and as you can see, everything I'm saying is turning into a transcript as I talk.
Well, before I continue, let me remind you that this video is not intended to replace medical advice. It's for educational purposes only. You should contact your doctor for a proper diagnosis and treatment plan for you. In case of emergency, go to the nearest emergency department or call an ambulance. So now, let's talk about the third type of pain, nociplastic pain. This pain is caused by neuroplasticity, or changes in the pain system that occur as a consequence of a nociceptive or neuropathic pain. The World Health Organization, in its 11th revision of the International Classification of Diseases, ICD-11, includes chronic pain as a diagnosis in its own right. It can be chronic primary and chronic secondary pain. Chronic primary pain refers to pain that exists despite complete tissue healing or pain that has no identifiable cause. This is nociplastic pain. Chronic secondary pain occurs in association with an underlying disease, and they can be nociceptive, neuropathic, or mixed. So, what exactly is nociplastic pain? In the analogy of the pain system, it's like this. There was a fire in a house, it burned the whole kitchen, it was bad. The house appeared on the local radio and TV news. The owners were super scared, their kids were screaming in the streets, but nobody got seriously injured or died. The insurance company fixed the kitchen and they got a new appliances and all new furniture for the kitchen. It looks much better than the old kitchen. However, the owners are still frightened by what happened. They are so afraid of this happening again that they are not using the new kitchen. In addition, the alarm office was terribly affected by this whole situation because when the alarm was triggered, the lady who received the call at the central office was distracted. She didn't send the fire trucks right away, and this delay contributed to the whole kitchen being destroyed. She feels guilty even years after the fire has happened. She still is afraid of making that mistake again. The co-workers are having regular staff meetings to solve the situation and help her. She keeps getting panic attacks every time that there is an incoming call from a house fire. So, this is nociplastic pain. The injury has healed, the body has been restored, but the person still has fears and memories of the pain. The person is afraid of using that body part, cannot sleep at night, is constantly fatigued during the day, cannot concentrate on simple tasks, cannot work, and their life starts spiraling down. The person is afraid of making a mistake, and fear is paralyzing. Now, even the autonomous sympathetic nervous system is alert all the time. Instead of enjoying their life and accomplishing what they would like to do, they are stuck in the memory of pain. So, like the family in the house, instead of enjoying the new kitchen, they are paralyzed by fear. And like the central alarm office, instead of forgiving a mistake and retraining the staff to avoid this from happening again, they are stuck in guilt, shame, and perfectionism. The treatment of nociplastic pain involves brain retraining, mind-body therapies. I have another video that I explain various evidence-based mind-body therapies that work for chronic pain. It is very simple to retrain the brain. The person first needs to understand that the pain is coming from malfunctioning of their pain system, that the pain is real, but it's coming from the fear of pain. Once the person sees that, it's easy to erase the memory of pain. It makes me sad when I see a patient with nociplastic pain for years and nobody ever told them this. And worse, they're prescribed multiple medications that are good for nociceptive or neuropathic pain, but they do nothing to nociplastic pain. Well, in case of opioids, it can even make nociplastic pain worse. We call this opioid-induced hyperalgesia. I have another video that I explain that. So how do we diagnose these three types of pain? This is done by taking a good history of the pain, their other symptoms, how it happened, what makes it worse or better. I have another video that I teach how you can explain your pain to your doctor, and there is a worksheet that you can download for you to get all the essential details of pain before you meet with your doctor. We also need to do a mental health screening to see if there are psychological symptoms, as these are important to differentiate nociplastic pain from the other pains. We do a physical exam to look at the body parts that are affected by pain, which include a sensory examination of the pain nociceptors in the skin, an examination of the parts that hurt, and a neurological exam. And finally, we may need to order some labs and tests to find out where the pain is coming from. For example, if we suspect there is a kidney stone causing pain, we might need to order an ultrasound to see where the stone is and to confirm the diagnosis. In chronic pain clinics, it's common to see patients who have these different types of pain simultaneously. Sometimes the person may have purely an ongoing nociceptive pain, inflammation, for example. This is common in arthritis. But some people will develop an exaggerated fear of pain, and that fear will paralyze them. And there are cases of purely nociplastic pain. An example is fibromyalgia. I have another video that I explain in more details what fibromyalgia is, and another video that I explain why some people have fibromyalgia, what predisposes a person to develop fibromyalgia, or in other words, risk factors that put a person at a higher risk of developing nociplastic pain. The good news about nociplastic pain is that it's treatable, and the results are incredibly satisfying. The brain is plastic, which means that the brain can heal itself. We can teach the brain to think differently, to not be afraid of pain, and let go of guilt, shame, and perfectionism. I have seen patients who overcame their nociplastic pain with very simple and quick mind-body therapies. Many people are pain-free today. Others still have some residual nociceptive or neuropathic pain, but they tell me that these pains are easier to manage and they are not debilitated by them. What was very debilitating was the fear they had from pain, which is now gone. They don't fear pain anymore. They stopped pain medications, they practice self-compassion, they meditate, they exercise regularly, and they're able to enjoy their lives and fulfill their dreams. Well, if you like this video, press the thumbs up here. Don't forget to subscribe to this channel and turn on the notifications button and watch my next video here.
Okay.
All right. Pause that. Okay. Cool. So I guess in a couple of like brief sentences, what's your thought? What's your overall like feelings about this video?
Yeah, I kind of like the simple classification for those pain, because from our school, I think in crowd school too, we kind of learn pain and we learn whole bunch of like 5 to 6 different names of pain and like why they happen. But I think a lot of them is just they can be like more easily classified into bigger categories, like what she presented with. Yeah, and I think the analog that she described with particular the nociplastic pain, I think is pretty good. Yeah, it is I think I will try to explain to some of the patients that I'm going to see with similar problem. So that is like more acceptable feeling. It's not because sometimes when we talk about nociplastic pain with patient, if we are using our words and not carefully, we may lead them to think that my physio think I'm crazy, I'm out of my mind. It's not your problem with your mind. It's just really like your perception with the pain, right?
Right.
So, but I think the way she present, if I use the similar way to present to some of the patients, I think those patients will be more acceptable to know this is their problem instead of really like a structural problem.
Yeah, and earlier when you said in physio school you learned about different like types of pain.
Yeah.
What other categories did you learn, or if you can remember some of the things that?
I don't really remember. Yeah.
Or are you talking more like about acute, subacute, chronic kind of?
I think the staging of this, like the healing, also we learn about this, and also like the type of the pain. I think uh for the types that I still kind of know today is actually this the first two, like nociceptive, neuropathic. That's the one that I still like remember from those lists. But other than that, yeah, but other than that, like other types of pain is actually, I would say, is they try to categorize the pain, uh, like from different structure, like too detailed.
Yeah, I think like you said, this is a global view of
Yeah.
rough not rough, but actually pretty specific categories of each type of pain, which under each type there's a whole bunch of other pain presentations or conditions, right? And I think you kind of alluded to it, but I think generally as chiros and physios, what we learn the most about and what we see the most about that we recognize is probably the nociceptive pain.
Yeah.
Right? When you have a acute ankle sprain or even like a chronic back pain or actually never mind, not chronic back pain.
No, yeah.
Let's say acute
Like
injury.
ankle sprain, acute injury.
Right, yeah.
There's like
Shoulders.
the problem.
Yeah, like sports injuries, even like MVA or motor vehicle collision type of injuries, WSIB injury, at least in the early stage, right? They're all nociceptive. And then neuropathic that we see often as well, things like radiculopathy, peripheral neuropathy, carpal tunnel syndrome, things like that, right? So those are very common, or is essentially our bread and butter in terms of diagnosis,
Yes.
and treatment. Yeah. And then with nociplastic pain, now, what do you think? Like, actually, I don't want to ask you like what percentage you see because it's hard to put a number on it. Do you think there are nociplastic pain that we see that we kind of overlook or we like didn't realize it is that, but it actually is what the problem is, rather instead of we're thinking it's just nociceptive or neuroplastic? Do you think there are a lot of those cases that we?
Yeah. In my previous workplace, I think that is actually a lot of patients. I would say maybe it will be up to 50% of my caseload.
50, like half.
Yeah, 50, half. Yeah, because it depends on setting too. Because like I work in a public hospital in Hong Kong, and usually who go to the public hospital in Hong Kong is like first is more of those lower income individuals.
Yeah,
they do not have access at like a private or really higher quality medical service. And then a lot of them, they just keep coming back to the same department. For say I had one of the case I still have like a good deal of memory is like that patient come to our physio department for like 40 years. 40.
Wow.
It's older than me. It's like at that it's like first year of my work. I was 22 at that time. 4 years is like double of my age.
That's right. That they had treatment for, right?
Yeah, and then like they he has like set amount of treatment that he want to do. So each time he come to here, I would say those physio usually just let him pick, and then listen what he want because he know the drills.
Yeah.
And I don't like it.
Yeah, for sure.
I don't like it.
Yeah,
and then I said, okay, it's all right for me to do this, but I need to explain what I think about your condition first. Yeah. But ultimately, I'm okay if you want to do all these things.
Yeah, that's the definition of insanity, right? Keep doing the same thing over and over again and expect different result. Sometimes.
Yeah, it's just the same question I asked him. So this machine you have done this maybe for a few years. How do you feel with that? So he said, similar, sometimes you sell, sometimes you don't. So why you are still sticking with this? Why don't you try something else? Have you tried like doing something on your own, really like engage? They said, no, I know this, I already know this. And I said, okay, so show me a few moves, show me what you are doing. He cannot show not a few of them. I would say it's not something that I would tell my patient to do. So I said, okay, so I want to teach you something first. You can have a try, and the things that you want to do, we can leave it for later session.
Yeah.
So I do it like this. So it definitely make my mind hard, my life harder. But this, like what the doctor said. Doctor said those patients with nociplastic pain receive medication wrongly. Those NSAID and even opioid. So they're just receiving something that is not helping them. Same thing happens for that patient for physiotherapy. Is just receiving things not helping them.
Yeah, and people are like very resistant to change, right? Whether it's patients, whether it's clinicians, right? So it's like something has always worked, or at least didn't do any additional harm, and that's comfortable. Then people tend to continue doing that, even though it's not really getting them anywhere. At least there's less perceived risk, even though that risk is that they're really not doing anything productive, right?
Yeah.
Where the clinical education comes in, how we communicate. Again, it's one of those things. Yeah, probably the previous physios that were working with this, they kind of just like, I don't want to, not my problem. I don't want to bother.
It's like that patient came to this like the same department 40 years.
Yeah.
So
yeah.
Why you are the only one talk differently? He will just judge you maybe in this manner.
Yeah.
Yeah.
So it's hard because we don't want to appear to be, or we're not judgmental, we don't want to appear judgmental at the same time. Like, you want to strive to be better, to help them better, because you haven't given up on them, right? Because perhaps the previous physio, they're just like, you know what,
just do what you want.
They're not gonna want to try, right? So it's great that you try, and that comes with practice as well. Sometimes like it's worth it to try, and sometimes after some time you're like, okay, you know what, maybe not worth my effort and my time, because they're so resistant to change, right? And that's something that like I often struggle as well as a clinician. But we ask questions like what you did. I think that really helps to get some understanding whether or not you could try a little harder or just back off, right?
And sometimes I feel like based on those experience in previous workspace, I feel like sometimes personality also plays some roles in nociplastic. Because the patient that I feel like they are having nociplastic pain are often those patients first, like what you said, reluctant to changes, and like second, they are like more fearful of like anything, like the more what is that, like discourage, like based on their pain, or even step out of the pain, or generally in their life. I feel that they are like a more discouraged, more negativity. I'm not sure about because some of the patient like that patient 40 years of experience in the physio department. I'm not sure it's the pain changing like that, or it's like that before he is having the I feels like they obviously like it's a vicious cycle.
Yeah, for
if
sure.
If you got like a bad chronic pain, you won't be a happy person. You won't smile, right?
Yeah. I think, like based on at least my understanding or limited understanding of psychology, is like certain personality types or categories of personality could predispose you or make you susceptible to certain beliefs or experiences, especially when you have pain. And then of course that, like you said, the pain feed back into it, right? So it's like, is it the personality? Is it a characteristic? Or is it because of the pain? Which one came first? It's hard to identify like a specific cause or not or whatever. However, we know that they feed into each other. So at the same time, even if we know which one came in first, it doesn't really change much about how we approach or how we help this patient to manage their pain, right? It's still through some education and asking some questions and showing them that we're really trying to support them. Now, going back to, I guess, nociplastic pain. Now, sorry, I'm trying to formulate my question. So, yellow flags, right? Are you familiar with yellow flags?
Yeah, pretty familiar.
Yeah, could you name like one or two or a few yellow flags?
Yeah, like I would say like for low back pain, for example, like reluctant to like move or thinking that they have a hard time engaging into like their daily life activity.
Yeah.
Even if like a more objective things, maybe they have a like a rigid belief, lower social economic status that may also play some role. Yeah, I would say these kind of things is one of those yellow flags. Yeah. And what I did in my previous practice, as soon as I feel like that person is more leaning to nociplastic problem, I will just grab one of those like outcome measures for example, like for low back pain, I pull out Roland Morris and let him do that. Like for the neck pain, I just pulled out the neck disability score.
Yeah.
I will just have that one for reference for me. Okay, so that person, how do they feel about it? Yeah. So this is what I did with my previous practice. It helped me a bit with identifying and also let me know how should I talk to the patient.
Yeah, absolutely.
Yeah, because some of the patient, like I know that patient is suffering from nociceptive pain. I would say I would like to talk about the pain more in depth. So I would usually ask, what day activity you do track the pain? How do you feel with the pain right now? Like, well, I can put my like question and our interaction more closer to his pain. But if I think that patient is more like having a nociplastic pain, I would kind of draw his attention away from the pain. I was asking, okay, how are you doing today? So, last week you said you had a hard time standing for 20 minutes. How are you feeling standing? So how about walking? You see any improvement, or you actually see it getting worse with our like treatment? So I will ask in this manner, just ask how they're doing with their functional activity instead of like asking about the pain. Like I won't ask you, okay, so when you're walking, how would you rate the pain? How would you rate the pain, like 0 to 10? I won't ask this question if I think that patient is in a nociplastic problem.
Right, because those are like pain focused, like we're really trying to concentrate on that pain. And we're actually trying to do the opposite, right? Of focusing on the function, their ability to do things. So when we ask those questions, we're just leading the patient to somewhere where we don't want them to be.
That's right. That's right.
That is, yeah. And it sounds like from what you described just now regarding dealing with nociplastic pain is that like the education piece is so important for patients to understand the pain they're experiencing is not something inherently structural or there's a biomechanical explanation, right? And again, you as a physio, me as a chiro, a lot of the things that we typically do or the things that patients typically expect us to do, like the manual therapy, the modalities, whatever, those acupuncture, those seem to really help potentially the nociceptive and maybe the neuropathic, but not as much as nociplastic. So if we just keep doing those things, thinking it's going to really be productive at helping nociplastic, then we're really missing the target by a long shot. And then of course, patient not going to be better, and then they either become skeptical of us or they get frustrated at themselves, and which could lead to another downward spiral. So by us providing right education, by them understanding, by us asking a question that so that we understand them better as well, I think that's probably the better approach. Yeah. And I think this ties into with the current understanding of pain, is that biopsychosocial model, right? There's a biological, which we all plays a role.
Like training for that, right?
I'm sorry.
I know. You mean like the bio aspect of the pain? We are pretty well trained, well equipped for that.
Yeah, the psychological, the social aspect, maybe we don't talk about enough, or maybe we just don't have enough understanding. However, when we look at pain more comprehensively from various aspects, then we will, be better off at helping our patients. Let's see. There's I wrote down some notes earlier. I wanted to kind of ask you and talk with you about. And the other thing is and a big thing is they talked about is like the medication, because they're physicians, physiatrists, and that's something that I guess not really not at all within our scope of practice. So do you talk, as a physio, do you talk to your patients about medication?
Actually, yeah, I actually do. But usually I will ask about like, first, what do you take any pain medication to manage your pain? And I will ask, okay, what is the name? So because back in Hong Kong, it's easier for me because I have access to all of the doctor notes, and all of the prescription from the hospital doctors. So I can see, okay, so you go to the orthopedic doctors, what orthopedic doctors prescribe to the patient. And I would also see the notes from orthopedic doctors, how they think about that patient. So it's easier for me to do it like back then. But for my future practice in Canada, if it is like more private, I think I would still ask this question. Yeah, one thing I want to set up is like how's the doctor's thinking? Like if how's the doctor is thinking? Like if he is going to have a meeting at orthopedic doctors, and orthopedic doctor provide them just Panadols, that tells something. And
what is that medication? I'm not.
I think that is more popular in like Asia, Hong Kong region.
What is it called again?
It's just painkiller,
Okay.
ordinary painkiller.
Is it an NSAID or is it just an analgesic?
Analgesic. It's like similar to
acetaminophen.
Similar effect.
Yeah.
I think they belong to the same family.
Yeah.
And then if the patient get prescribed of NSAID, or even like some more serious things like opioid things, so I will have a understanding on how their current pain being managed. But and also I think one thing that I always receive from my patient, even back in there and right now, also the patient usually ask, okay, shall I try to reduce the dose of the pain medication because I feel better? Or they think, like before coming to therapy, should I not take the medication because we are doing pain management here? So I don't think I need that medication, or maybe on the morning dose, I can skip that and then come here in the morning, and then I have my afternoon dose. So I often have this kind of question from patients. Usually,
what do you say to them?
I would say the safest way is to do it just follow your doctor's prescription. it is like out of our specialty to talk about medication. So like if the patient tell me, okay, the doctors ask me to take it as needed, I will just, okay, then take it as needed. If you really need to feeling the pain kind of increasing, maybe you take one dose and continue with the exercises with the lightest one. So I will kind of go into this manner. But down in my heart, I feel like if the patient really think he's getting better, like feeling less pain, I think he should try to lower the dose of medication. But also it comes to what's the cause of the pain. Like if it is like nociceptive pain, it may be still still a good idea to keep those NSAID just to like calm down the structural inflammation, some sort of like that.
Yeah.
If it is like nociplastic pain and is taking some really strong medication, but the patient is feeling better, down in my heart, I would like to try to reduce, because when you're taking pain medication, it's actually, I feel like it's reinforcing that you are having a pain.
Yeah.
So, but like because of our like the ethical and our training, we cannot talk it like this. So the best shot is just I will ask how's the doctor's prescription. So follow the prescription and then done with the conversation.
Yeah, definitely. I think how I typically approach is that one patient asks me, should I take this medication or should I increase or lower? For me, I really make it clear that, hey, this is outside my scope of practice. I cannot tell you to take it or not to take it. At the end of the day, it's still your choice. So I tell patient it's your choice, right? Like even if their family doctor tell them to take it or not to take it, they still have a choice because they're the one who's physically taking them.
Yeah, that's right.
However, I do tell them, it's like, look, even though I can't tell you to take or not to take it, just, like you said, follow your family doctor's advice, follow the advice of a pharmacist, because that's within their scope of practice, not with our scope of practice. So that really prevents you from being liable in case you tell them don't take it or take it,
that's right.
increase or decrease. Then if something happens, they could sue you, or at least if there's an adverse reaction, you'll feel extremely guilty that something happens. So I always tell patient, even when they say, well, Taryn, a topical, right? I tell them if it is a DIN drug identification number, I cannot tell you anything. But it's like a natural supplements, like things like and Biofreeze, for example, active ingredient is a menthol. It actually is not a Health Canada approved medication. It has I think a natural product identification number. I forget the acronym. So that I can say, okay, you use as needed. If you feel it's helpful, then use it. However, if it's a drug, I absolutely tell them no. I'm telling you anything to take or not to take. Right. And oftentimes I just say, hey, just go to the local pharmacy. Like talk to the pharmacist. They can ask you some questions, and because they're trained in that field, right? So it is tricky because at the end of the day, like we want patients to get off medication because we don't want them to become dependent on it, and we don't want any other side effects come from medication. As we know, most medications has side effects, right? And oftentimes people don't even realize those. Even things like Advil, if you look at the label, or if you actually look up some data, the chance of like GI bleed is like pretty high.
I
don't know exactly the stats, is like it's way higher than any adverse reaction that they would get from like getting a chiropractic manipulation and getting something serious. So it's like, but those are things that like I just usually don't talk to patients about, because it's like,
it's like a too tricky question to
it's tricky.
He answered by us.
Because also like as a chiropractor or physio, like even though we have some training in medication and pharmacology stuff within our curriculum, but it's like,
It's like
how credible are we?
surface, just a scratch on it.
Exactly. Yeah, we just don't know the ins and outs. Even for family doctors and for physicians in general and for pharmacists, they really need to have a comprehensive like review of the medication or do some other tests. Yeah.
Yep.
Sorry, I think we went a little too long on medications, even though it's outside of our scope of practice. But
I have one question for you too.
Sure.
Yeah, because like a lot of patients, whether it's back in Hong Kong or here, they do a lot of imaging. It's like the pain is getting serious and really common. So if you see so if it is like in a first situation, the pain is actually you feel it's not correlating with the imaging result. How's your wording with those patients? If you think, and the second scenario is you feel that they are kind of correlated, I think this is easy. But the first one is kind of hard, particularly if the patient already was told by someone else, okay, because you have this in your image, so that caused your problem. So that is that I used to have the similar conversation with a lot of patients. I did it in my way. Some patients like it, some patients don't. So, but I'm not sure about your way. So I would like to hear about your ways.
Yeah, part of it is like it doesn't really matter if the patient like to hear what you say to them or not, because you're not there to make friends per se. You're there to be a professional, give the patient your best professional advice, giving the current evidence, given the proof or imaging results or your clinical examination and diagnosis, right? So, however, you could definitely come off nice and not being a jerk when you explain to patient or when you disagree with patient. However, I think, to really get to your questions, like if a patient have some findings, it's like a normal exam and then they have pain. How do you explain that? Versus, is essentially what you're saying? They have some sort of
or for say they have like prolapsed disc, lumbar spine prolapsed disc. And then actually like what they are presenting is another problem. Like they think, okay, prolapse this, so I have this pain. But when you do examination, maybe you feel okay, it's like those stiffness or like lack of movement in the vertebral joint. So these are a bit more tricky, I think.
Yeah. So part of it is like, I asked them, okay, if they have signs of disc herniation, degenerative, and then they have localized low back pain, but without radiculopathy, radiation numbness, tingling, neurological stuff. So they think that their back pain is due to that disc. So part of it is just like, why do you think that? And I ask them that, and then they give you a response. Could be off, could be somewhat correct, and then you just tell them, okay, I understand what you're feeling, you're experiencing, you're describing, and then you repeat them back to what they said so that they know that you heard them. And then you ask them, do you want my opinion or my advice? Because clearly they came to see you to hear your advice, to get a opinion, to get assessed. So when you ask that question, their chances are they're going to say, yes, please, Jason, please, Thomas, tell me what you think. And through that, hopefully you can capture the gist of that condition, provide that education in a timely, effective manner so that it gets through to them. And once they understand, then it will be a lot easier. So oftentimes I tell people is like, look, X-ray, MRI, or a CT, it's just a picture of you, or it could be multiple slices of a picture of you given that moment, right? However, a picture does not explain pain. A picture only explains structure, and pain is more than just our structure, right? That's usually how I describe. So it's kind of like when I give this analogy oftentimes. Let's say, hey, Thomas, I just I just met you
Mm-hmm.
and you're angry, you're making an angry face. I take a picture of you. I give it to a stranger. What's the stranger going to think of you? They're going to think you're probably a bad person or a really angry person. But then on the other note, when I caught you at a happy moment where you're smiling, we're cheering, I take a picture of you, give it to another person who doesn't know you. They're probably thinking you're one of the happiest people, right? But still, like still the same you. It's just that at this moment in time, you're presented differently. So it doesn't always match your true personality, which is neither completely happy, neither completely angry, right? So
Yep.
yeah, picture is just a picture in that moment in time. So that's how a combination of those couple approaches is how I.
Mm.
Yeah. Does that answer your question?
Yeah, I think that is also like a good thing to tell the patient. Because sometimes when they do an imaging, they feels like the imaging is the gold standard. Like they expect everything to be explained by the images.
Right.
Link their like the current problem, current pain, current disability with the images too.
Yeah.
But like what you said, I think I can add in like this an analogy about the taking the picture thing.
Yeah. You just have to like word it smoothly and not butcher like what I just did it. So actually, while we're on that topic, remember a while back I asked you how to define pain. I actually asked a few people, I think maybe anyhow, our colleagues,
Sure.
and nobody appeared to be able to give me a concrete, like a solid answer what pain is. Is like we're all dancing around it. So let me just share my screen if you don't mind, and I'll go
Problem.
over the terminology that's accepted.
Sure.
Yeah, I think I may have shared this with you before. This is from the IASP, the International Association of Study of Pain, I think. Let me just blow it up. Yeah, International Association for the Study of Pain. So they had a couple iterations of the definition, but the most up-to-date version is from 2011. It may have been updated since then, but the new definition state that pain is, so it has a couple points. So I just wanted to point these out. So first is an unpleasant sensory emotional experience. So that essentially means that pain at the end of the day is a feeling, is an experience. There could be an emotional component to it, and there could be a sensory component to it, which means that there could be some sort of physical injury like nociceptive pain or neuropathic pain. And the emotional, that could potentially have some correlation with the nociplastic. And it's associated with or resembling that, associated with actual or potential tissue damage. Again, it may allude to that there could be some physical damage, maybe there isn't, right? And it's expanded upon by the additional 6 key notes and the etymology of the word pain for further valuable context. So these key notes are pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors, hence biopsychosocial model. And pain and nociception are different phenomena. So again, pain is a experience. Nociception is like a physical sort of stimulus, and our nociceptor picks that up and send it to our brain. So they're different. Pain cannot be inferred solely from activity in sensory neurons, which is essentially what I just described. Through their life experiences, individuals learn the concept of pain. So that means how we view pain is molded through our life experience. It could be the same injury. However, if you are an athlete experiencing pain regularly, then you overcome that pain, versus me who's never experienced that type of pain. All of a sudden I get hit and then I have developed chronic pain. How we view the pain is going to be completely different, even though it could be the same body part, for example. A person's report of an experience as pain should be respected. So no matter how the person explains their pain, we need to validate their experiences, validate their concerns. It's never that they're just making it up. It's all there in their head. although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. A lot of nociplastic pain has this feature, right? The body started to protect us. However, that fire alarm just became way off. So it's coming off when it doesn't need to. So it's affecting our ability to do things. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So most of us, we can explain our pain. However, oh, sorry, I didn't share the right screen. So here, let me share this other screen here. Of what I was reading. Sorry, Thomas.
Yeah, it's okay. I kind of
so
picking the important points from that.
yeah, so this is the definition,
Yeah.
and then the 6 points. So this last point is essentially that, yeah, words is just how we describe pain. However, we could have like nonverbal cues, like we're grimacing, we're holding on to an area, we're slow to act, slow to turn, get out of bed, those other things. And of course, non-human animals also experience pain. So yeah, so I'm gonna leave this on. Any thoughts on the current definition of pain by IASP?
I think one thing I will also do after our discussion is I will look on the previous definition, like the older edition. I want to see how things change.
Yeah.
Because like last time I think Nathan talked about like the medicine right now is kind of surrendering to purely structured problem. Yeah, I think a lot of the old school things that I learned back in physio school is we kind of focus a lot of things on structure. Structurally, everything happens because of the structure. But
biomechanical in nature.
Yeah, biomechanical. Yes, but like when I start to work, I realized no, a lot of like biomechanical problem that cause the problem maybe like 30-40%, but like much more that is maybe it start like a biomechanical and then turns into like a nociplastic pain pattern. And or maybe starting purely as a nociplastic flow. Yeah. So I think currently the definition with the pain I think is quite comprehensive. But I would also quite interested to see the previous definition. I will do it after our discussion.
Yeah, and I think with progression with science, with research, understanding, things has to have changed. I think maybe another 5, 10, 20, 50, 100 years from now, that definition could be way different than what we're discussing.
Yeah, definitely. Because it's a science, right? The nature of science is ever changing.
It's exactly. Yeah. It's always evolving, right?
Always changing. Like sometimes I like recently I also looked into some paper like which I read when I was still learning about physiotherapy, which is something like 2014, like 10 years ago. Paper. And I feels like when I'm reading those paper, the things they talk about is already not quite the mainstream thought with the most updated paper recently.
Yeah,
so it's pretty impressive to see the change already. That's that a lot. It's just like this, maybe 10 years.
Yeah.
Like what is that is ever changing.
Yeah, definitely. Like even now, when I look up something on PubMed, I don't even bother looking at things more than like 5 years.
Yeah.
Well, I do, but still, usually I set the filter to within the last 5 years. Even 10 years is probably the most I want to go back to because like,
sometimes I think also I like to see some of the newer paper. They sometimes refer to some older more well-known article. There's like particular for some of the problems, like some of the arguments, they have like a few particularly well-known paper they like to refer to. And then when I look at those papers, I'll say, oh, it's pretty old and I don't think of this way anymore.
Yeah, I think
Not this way when I was in school, but not right now that much.
for sure. Yeah, there's certain things for sure have changed. And then on the flip side is that like some fundamental like principles and like theories are still holding true. They've came from a solid basis, solid ground, right? So that's very interesting because like even for us clinicians, it's hard sometimes to like see these things, and for patients it's even harder to see, right? And also like we're not researchers, so like a lot of the details we wouldn't even know. So it's good that we keep reading and keep learning and bettering our knowledge so that we could help people better, but also like just build our own character, build our own wealth of knowledge and toolbox. Let's see. Nociplastic. Coming back to nociplastic pain.
Sure.
Can you think? I know they talk about a couple of different conditions, like fibromyalgia being one.
Yeah.
Can you think of any other specific diagnosis that's considered? I have one in mind that's like the kind of want to brush on, but can you think of any?
Sometimes I feel like the regional complex reflex syndrome. That one is pretty.
That's exactly what I was thinking. Yeah.
I don't know about that one because why I kind of have this one back in my mind is because I was studying for my exam, and there's like a session about this one.
Yeah,
also, they have a session about fibromyalgia.
Yeah,
but there is a session about like complex regional pain syndrome. So I look at it, I saw, and I think it's been a while because like last time I see and like study this thing is like when I was in maybe second years of my physio school. Like after I graduated from school, I didn't really think and talk about or even get some diagnosis about this problem that much. But I'm not sure about that. I think sometimes also for fibromyalgia, for a bit more research, this may also become one of those terms like shoulder impingement. You know what I mean, right?
Yeah.
So it's like for example, shoulder impingement just want to just make that shoulder pain into one specific like causes, but like the more updated one is called subacromial pain syndrome, right? So I think fibromyalgia or complex regional pain syndrome might be the next one that fall into the phase of shoulder impingement. Will fade away soon.
Yeah, and fibromyalgia is already a condition, a diagnosis by exclusion, right? You know, this is not that, it's not this. We tested for all these things. Okay, well, it follows all these how it is. It has these presentations, and we'll call it fibromyalgia, right? Yeah, complex regional pain syndrome is one of those things. Is like it is complex.
It's complex.
Right? So I think from my understanding is that like there was some sort of trauma, or whether it's through previous surgery, through like a traumatic incident, ankle sprain,
like the sympathetic nerve system.
Exactly, and then it kind of the acute, the nociceptive pain has gotten better, and then there's neuropathic component to it, and then it just became this chronic long-term thing that we just cannot seem to get a lot of traction with any type of therapy. On Netflix, there is a documentary that follows this young girl who was eventually diagnosed with this condition. I forget, it's like Caring for Molly or something like that. So it's a really sad story. So I watched it last year, actually. I don't know if it's still on Netflix. They kind of gave some in-depth view of this condition and how it affects the people around them, like the parents. Yeah, it's quite interesting. And how the healthcare system has just like failed so much for this young girl. Well, that might be something you can look into if you want to learn a little bit more about it. But yeah, and my first time hearing about this condition, at that time, like the name wasn't even complex regional pain syndrome.
I think they have another name, but I forgot.
Yeah,
Like
Sudex.
Sympathetic reflex syndrome, I think.
Yeah. There's a couple of different names for it.
Yeah.
Yeah. When I first heard it, it was like back in 2009 or 2010 when I first worked as a physio assistant at a clinic. My mentor, who was a physio, he diagnosed, or there was a patient that presented with that, right? So I was like, oh, what is this? And then later when I went to chiro school, I learned about it, and then like just forgot about it for years until the documentary like last year. I was like, oh, okay. And I personally haven't seen, I don't think I've seen a case, or if I've seen it, I probably missed it.
Yeah.
Yeah, but
I think like these two words try to explain something. They are just trying to give a name for the patient who cannot find a mechanical cause or structural cause for the discomfort they're having.
Yeah.
So they just give a name like that.
Yeah.
Those two, but I think these two names are separate from like mechanical low back pain or like chronic low back pain. I think like that word is another story, but these two words I feel like they are just trying to give a name for something that they cannot find, or we like for the science right now we still cannot figure out what's happening with those.
In general, when you call the condition a syndrome, it's essentially a collection of
different things.
It could have some of these, might not, and hence it becomes a syndrome. So anytime when it's a syndrome, it's just not super easy to manage, so it's like a lot of it up to almost interpretation, right? So cool. Alrighty, I think it's been over an hour. So do you have any other like concluding thoughts or questions for me, or
Yeah, I think the concluding thought is we don't have to think the pain is too structural, too specific to something, to some structures. We can try to be broad and think our patient, we kind of think about them, okay, so what they're experiencing with their pain, and then we kind of give our treatment based on what we are thinking about their problem. Like what the doctor said, there may be a mix of nociceptive and nociplastic pain. When we are treating our nociceptive, and we also have to still stick with our continuous treatment with the nociplastic pain. So I think that's maybe the biggest takeaway from me for today's session.
Yeah, absolutely. I think my takeaway is pretty much the same thing. It's like once we understand the bigger picture of how we categorize these type of conditions, sometimes the actual diagnosis, of course, diagnosis matters, but then it might not matter in the grand scheme of things because we know what category it is. So we know which toolbox we need to open up in our knowledge box so that we can give the more appropriate way of managing or triaging these conditions. And then and then what was I gonna say? Yeah, so essentially the diagnosis matters, but then it doesn't matter that much. We just have to treat the person as a person and go from there.
Yeah.
Okay, well, Thomas, thank you so much for your time.
No problem. That's a pretty good and meaningful discussion today.
Yeah, that was definitely it, and you're very knowledgeable on, even though you've been in practice for just a couple years, it seems like you have a good foundation and lots of knowledge, so keep up the good work.
Thank you.
So I guess today I will edit this video a little bit, put on some timestamps of what we discussed. I'm not really great at editing videos, but I'll put it on YouTube, and then we'll
Sure,
Yeah.
no problem.
Okay.
Okay.
Alrighty. Thank you so much.
So sure. So let me know also about our next session next month. So
Yeah.
I can prepare the things that I need to talk about.
Sounds good. Yeah, we'll discuss in private or in that group and
Okay,
see.
no problem.
Okay. Alrighty. Thank you. Have a good night.
Yeah, you too.
Peace.